Okay, let's unpack this. We're diving deep today into something that's, well, absolutely fundamental in understanding heart health. The echocardiogram. Think of it as an ultrasound of the heart. And if you've ever seen an echo report, you know it can look incredibly complex.
Oh, absolutely. Filled with terms and numbers. It can feel like a foreign language.
Exactly.
But echocardiography, it's such a cornerstone tool in cardiology. It gives doctors these real-time images, measurements of the heart structure, how it's working. It's just invaluable for diagnosis, for tracking conditions.
And our guide for this deep dive is a practical, really comprehensive resource, the kind used by the folks who actually do these studies and interpret them.
Yeah, it's packed with details, protocols, clinical context.
So our mission today is to kind of translate that complexity for you, the listener. We want to pull out the crucial pieces, the essential knowledge, so you can feel much more informed when you see info about echocardiograms.
Like getting a shortcut.
Exactly. A shortcut to understanding what really matters in these reports.
We're aiming to help you understand the why behind all those numbers and descriptions you might see.
And here's something I found really interesting right off the bat. Understanding an echo isn't just about spotting, the big problems.
Right.
A surprising detail from our source is that knowing which findings are almost never clinically important, well, that's just as valuable.
It really is. It can save a lot of unnecessary worry. We'll definitely highlight some of those.
Okay, so to start, if you're getting an echo, it's helpful to know that not all echo studies are created equal, right? There are different levels.
That's exactly right.
Yeah.
The source breaks it down into a few levels, sort of stepping up in detail. At the most basic end, there's what they call a basic scan.
Okay.
This is usually super quick, often when in urgent settings, maybe the ER, or just for a rapid screening check.
Like a quick look.
Yeah, its main goal is just to spot major, potentially life-threatening things that need immediate attention. Like, is there significant fluid pressing on the heart? Is the right ventricle huge, suggesting a big clot in the lungs? Or maybe just confirming things look broadly normal.
Got it. Like a quick health check with the ultrasound probe?
Precisely. Then you have a focus study. This goes a bit deeper than the basic scan, but it's still often targeting specific questions.
Like what?
Maybe following up on something, like checking if the heart's pumping strength is getting better after starting a treatment, or monitoring patients getting certain meds, like in cardio-oncology, just making sure their heart function is holding up okay.
Right, right. So you go from that quick glance to a more targeted look. What about the kind of scan most people might get if they're being properly evaluated for a heart condition?
That would typically be the minimum standard study, and the source really emphasizes this one. Why? Because it's designed to confidently exclude significant problems.
Okay, so it's more thorough.
Much more. It follows a strict protocol, a required set of views and measurements. This helps reduce variability between studies and operators. Its purpose is really clear. Confirm normal structure and function, minimize the chance of missing something important, and crucially, make sure studies can be accurately compared over time.
So this is the comprehensive but standardized evaluation, the one you can rely on.
That's a good way to put it.
Mm-hmm.
And then, for the most complex cases or maybe research, there's the comprehensive study. This is done by highly experienced specialists, usually using very high-end equipment.
Okay. So once the study's done, all that information goes into a report. The guide talks a bit about how these reports are organized. What should a good report actually tell you?
Well, beyond the obvious patient details, it needs to identify who did the study, what machine was used.
Right.
It should also describe the image quality, because sometimes, it can be harder to see everything clearly depending on the patient's body type or breathing.
Makes sense.
Then, of course, it describes the findings, both how the heart looks, the morphology, and how it's working, the function. But crucially, the source stresses this. The clinically important measurements need to be highlighted and discussed in the text, not just buried in a list of numbers somewhere.
Ah, so the narrative part matters, connecting the dots.
Exactly. The narrative needs to explain what the numbers mean in context. You don't want doctors having to hunt through pages of data to find the critical stuff.
Yeah, definitely not. And what if something really urgent is found, like a critical finding?
There's a system for that, or there should be. It's called escalation for urgent advice. Labs need clear protocols for immediately flagging critical findings.
Like what kind of findings?
Things like that fluid buildup causing pressure, we call it tamponade. Signs of a big pulmonary embolism, a severe new valve problem, maybe a mass or a clot.
Okay, serious stuff.
Very serious. And these findings need to be communicated immediately to the referring doctor or cardiologist. And that communication needs to be documented too.
Right. Okay, let's loop back to that point you made earlier, the one about knowing what not to worry about. This sounds super practical. For someone looking at the report or maybe hearing terms used, what are some findings the source says are almost never of clinical importance?
Yeah, this is really useful stuff. The guy lists a few things you might see mentioned that on their own typically aren't a big deal.
Like,
Okay, first, mild tricuspid and pulmonary regurgitation. This just means a tiny bit of blood leaking backward through the valves on the right side of the heart.
the ones going to the lungs.
Exactly. The source flat out states this is a normal finding. Lots of healthy people have it. It's like a door that doesn't seal perfectly airtight, but is not really leaking in any meaningful way.
Okay, good to know. What else?
Isolated moderate tricuspid regurgitation. So even a slightly larger leak in that same tricuspid valve usually isn't important if, this is the key part, if the right side of the heart looks normal, works normally, and the left side of the heart is fine too.
So context matters.
Always. Then there's mild mitral regurgitation. A small leak in the mitral valve, the one on the left side, between the top and bottom chambers. Again, often seen, often not clinically important if the valve itself looks structurally normal and the main pumping chamber, the left ventricle, is normal size and function.
Okay.
And one more. A finding called a sigmoid septum, or septal bulge. This is just a common age-related change in the shape of the wall between the two main pumping chambers. Very common in older adults.
Does it cause problems?
It might sometimes cause a heart murmur that a doctor can hear, but on its own, the source says it's usually not clinically significant.
Wow. That's actually incredibly helpful. Just knowing those things are often benign could prevent a lot of anxiety for people.
Absolutely.
Okay, let's unpack this a bit more. Now we've got a sense of the different study types and how reports are structured. Let's dive into what those reports are actually measuring, the different parts of the heart. Starting with the powerhouse, the left ventricle LV, what are they assessing here?
Right, the LV. The main pump pushing oxygenated blood out to the entire body.
Yeah.
So yeah, its assessment is critical. Reports look at its size.
How big it is?
Exactly. They might use simple linear measurements, like a diameter, but more importantly, especially now, they look at volumes. Measuring the volume inside the chamber when it's full, just before it squeezes, that's the end diastolic volume, or LVEDV, and then the volume left after it squeezes the end systolic volume, LVESV.
Why volumes?
They get a much better sense of the overall size than just a single line measurement. And these volumes are usually indexed to your body surface area.
Meaning adjusted for body size.
Yeah, so you're comparing apples to apples, basically. Is your heart volume appropriate for your build? The source provides normal ranges for these index volumes, and they differ slightly for men and women.
Okay, so is it too big, too small, or just right?
Pretty much.
Yeah.
They also look at wall thickness. Is the muscle wall normal thickness, or is it thickened? That's hypertrophy. And reports will often grade that mild, moderate, or severe hypertrophy.
And then, maybe the most important part, how well it actually pumps, systolic function.
Right. This is absolutely key. They look at regional wall motion. How are the different segments of the LV wall squeezing?
Like piece by piece.
Exactly. If one part isn't moving well, or moving abnormally, it can be a sign of reduced blood flow to that specific area, maybe from a blocked coronary artery. This is vital information, especially if someone's had a suspected heart attack. They'll describe which segments are affected and relate it to the likely artery involved.
And the overall pump strength, not just the regions.
That's global function. And the big number everyone hears about is the left ventricular ejection fraction, LVEF.
LVEF.
That's a percentage. It tells you how much blood the LV pumps out with each beat relative to how much was in it just before it squeezed. Generally speaking, above 50%, maybe 55%, is considered normal. But the source makes a good point. There can still be subtle issues, even if the LVEF number looks normal.
Really? How do they pick up on those more subtle problems then?
Well, they might use other measures. One mentioned in the source, it's not the most intuitive name, is the VTI subaortic, or LVOT VTI.
Okay, what's that?
Think of it like this. It measures the distance the column of blood travels as it's ejected out of the heart with each beat. It's a good marker of stroke volume, how much blood is pumped per beat.
I see.
And what's fascinating here, the source highlights this. In acute critical settings, say, someone comes in with shock or acute heart failure or a big pulmonary embolism, if that VTI subaortic measurement is less than 15 centimeters. That's a significant finding.
Why significant?
It suggests the heart is really struggling to push out enough blood volume with each beat. And in that acute context, it points towards a poor prognosis. It's a warning sign.
Wow, so that specific number, less than 15 centimeters, can act like a critical warning light in an emergency situation.
It really can. And for picking up even earlier or more subtle changes in function, especially in specific situations, they use more advanced measures like global longitudinal strain, GLS.
Strain, like stretching.
Kind of. It looks at how much the heart muscle fibers themselves are shortening lengthwise during the contraction. It's a more sensitive measure of muscle function and can sometimes detect dysfunction before the LVEF number starts to drop.
Where would they use that?
It's particularly useful, for example, in cardio-oncology monitoring patients getting chemotherapy that might potentially damage the heart. The source actually gives specific thresholds for concern based on GLS values in that setting. Like, if the GLS worsens by a certain percentage, it's a flag.
Interesting. Okay, so beyond pumping blood out, the LV also needs to relax and fill up properly for the next beat. That's diastolic function, right?
Correct. Diastole is the filling phase.
Yeah.
This is all about how compliant or maybe how stiff the LV muscle is when it's relaxing and refilling with blood from the left atrium.
How do they measure that stiffness?
Echo assesses this using several parameters. They look at the pattern of blood flow into the LV, across the mitral valve, things like the E wave and A wave velocities, the EA ratio, the E wave deceleration time. They also use tissue Doppler to measure how the heart muscle itself is moving during relaxation, specifically the E prime velocity at the base of the LV.
Sounds a bit technical.
It can be, yes. But the takeaway for you, the listener, is whether the echo suggests the heart is filling easily and normally, or if there are signs of increased filling pressure, meaning the ventricle is stiff and resisting filling.
And does anything else get bigger if the LV is stiff?
Yes, absolutely. They also measure the size of the left atrium, LA. That's the chamber collecting oxygenated blood from the lungs just before it enters the LV. If the LV is stiff and difficult to fill, pressure can back up, causing the LA to enlarge over time. An enlarged LA is often a key sign of diastolic dysfunction. The source notes a normal LA index volume is less than 34 mmol2.
Okay, wow. So LV size, wall thickness, how it squeezes regionally and globally, and how it relaxes and fills. That's a huge amount of information just from that one chamber.
It really is.
Now let's talk about its partner on the other side, the right ventricle, RV. The source highlights this one as crucial, but maybe sometimes overlooked.
It definitely is crucial, and perhaps historically hasn't always gotten the same attention as the LV, but that's changing. The RV is responsible for pumping that deoxygenated blood returning from the body to the lungs to pick up oxygen.
So its function tells you about the lungs.
Its function gives vital clues, especially about conditions affecting the lungs themselves or the pressures in the pulmonary circulation. RV failure is a serious issue.
What are the key things Echo assesses for the RV? How do they measure its function?
Well, first, they need to get good views. And sometimes the RV can be tricky to see perfectly. They use specific views designed to capture it well, like an RV-focused apical view. Key measurements include its size. The source mentions measuring its diameter at the base, a specific measurement that can indicate enlargement if it's over a certain value.
And function, how well it pumps.
For function, they use several measures. A common one is TPSE, that stands for tricuspid annular plane systolic excursion.
PAPSE, okay.
It's a relatively simple measure. It looked at how much the outer corner of the tricuspid valve ring moves up toward the apex, the tip of the heart, with each beat. It's basically a proxy for the RV's longitudinal squeezing power.
So more movement is better.
Generally, yes. They also measure something called RV fractional area change, or FAC. This is kind of like an ejection fraction for the RV. It looks at the percentage change in the RV's area, from its biggest, relaxed, to its smallest, squeezed.
So a smaller TPSE value or a lower FAC percentage would indicate weaker pumping.
Exactly. The source gives specific thresholds that are generally considered abnormal, like TPSE less than 17 millimeters, or an RV FAC less than 35%. These suggest RV systolic dysfunction.
And what does it mean if the RV isn't pumping well?
Well, this is where it gets interesting. The source points out that an RV that isn't squeezing well, they might call it hypokinetic, is a really strong clue. It usually suggests one of two main things. Either the RV is struggling against abnormally high pressure downstream, like in severe pulmonary hypertension.
Pushing against resistance.
Right. Or there's a problem with the RV muscle itself, some form of myocardial disease affecting the right ventricle.
And the source mentioned a potential pitfall with measuring TPSE, a common mistake.
Yes, it did. It's apparently quite easy to underestimate the TPSE value, if the measurement cursor isn't perfectly aligned with the direction that the valve ring is actually moving. So careful technique is really important to get an accurate measurement.
Good point. Now, related to the RV and the lungs is the whole issue of assessing pulmonary pressure and hypertension. High pressure in the lung arteries is bad news, right?
Yes, elevated pulmonary artery, PA systolic pressure, is definitely a marker of poor outcomes in many conditions.
How does echo help figure that out? Can it measure the pressure directly?
Not directly, no, but it can estimate it quite well, most commonly by using the Doppler signal from that tricuspid regurgitation, the TR jet we talked about earlier.
The backward leak through the tricuspid valve?
Exactly.
Yeah.
They measure the peak velocity, Vmax, of that backward jet. The logic is based on physics. The faster that blood is forced backward, the higher the pressure difference must be between the RV, during systole when it's squeezing, and the right atrium.
So faster jet equals higher pressure difference.
Precisely. There's an equation, the simplified Bernoulli equation, that relates velocity to pressure gradient. Pressure gradient is roughly 4 times the velocity squared, 4v2. By adding an estimate of the right atrial pressure to this gradient, you get an estimate of the RV systolic pressure, which, in the absence of valve problems on the right side, should equal the pulmonary artery systolic pressure.
Okay, so a high TR velocity suggests high pulmonary pressure. Are there specific cutoffs?
Yes, the source provides thresholds for assessing the probability of pulmonary hypertension based on that peak TR velocity. For instance, a TRV max of 2.8 meters per second or less suggests a low probability. If it's higher, say between 2.9 and 3.4 meters, it bumps up the probability. And if it's greater than 3.4 meters, that indicates a high probability of pulmonary hypertension.
Are there other clues echo looks for?
Yes, definitely. They look at other signs that suggest high pressure, like the shape of the wall between the ventricles, the size of the RV and right atrium, and also how quickly blood accelerates out of the RV into the pulmonary artery. A very short acceleration time, the source mentions less than 80 milliseconds, is another strong indicator that pulmonary pressure is likely high.
And what about estimating that right atrial by-air pressure you mentioned needing for the calculation?
That's done more semi-qualitatively. They look at the inferior vena cava, IVC, that large vein bringing blood from the lower body into the RA. They look at its diameter and how much it collapses when the patient takes a sniff or breathes in deeply.
How does that tell you the pressure?
Well, if the pressure in the RA is high, the IVC tends to be dilated, kind of plumped up, and it won't collapse much or at all with breathing. If the pressure is low, the IVC is usually smaller and collapses significantly. Based on the size and collapse, they assign an estimated RA pressure like 3, 8, or 15 millimilli Hg. The source does note, though, that sometimes the IVC findings don't perfectly match other signs of pressure. It's an estimate.
Okay, that makes sense. Great. So we've covered the main pumping chambers, the ventricles, and pulmonary pressure. Let's move upstairs to the collecting chambers, looking at the atria and the walls between them, the septum. You mentioned the left atrium, LA, earlier in relation to LV filling problems.
Yes, the left atrium, LA. It collects that oxygenated blood coming back from the lungs. As we discussed, its size, particularly its volume index to body surface area, is really important. It reflects the load on the LA, often related to LV filling pressures or mitral valve issues. And again, that normal limit cited is generally less than 34 LM/LM2. And enlarged LA is a significant finding.
And the right atrium, RA, on the other side.
The RA collects the deoxygenated blood coming back from the body. Echo measures its size too, usually its area. An enlarged RA is often seen when the RV is enlarged or failing, or if there's significant tricuspid valve regurgitation or high pressures on the right side.
What about the walls separating these chambers, the septum? Specifically the wall between the two atria.
Right, the atrial septum. Echo looks closely at this wall. Common findings here involve potential holes or communications between the atria. Things like a patent foramen oval, PFO, or an atrial septal defect, ASD.
A PFO, that sounds familiar. Isn't that something a lot of people just have normally?
It is actually.
Yeah.
Up to maybe 25% of adults have one. It's a small flap-like tunnel between the atria that was open during fetal development, but didn't completely seal shut after birth in everyone.
Is it usually a problem?
Often, it's a no consequence. But sometimes it's assessed if there's a reason to suspect it might be related to a problem, like a stroke where the cause isn't obvious, cryptogenic stroke. The concern is that a small clot from the veins could potentially cross from the right atrium to the left atrium through the PFO and travel to the brain.
How does echo check for that? You mentioned a bubble study.
Yes, exactly. A bubble study is the standard way. Huh. They inject saline solution that's been agitated to create tiny microbubbles into a vein, usually in the arm. Then they watch the heart with echo. Normally, those bubbles fill the right atrium and ventricle and go to the lungs. If there's a PFO, you'll see some of those bubbles appear in the left atrium fairly quickly after they fill the right atrium.
How quickly?
This source gives a specific criterion. Seeing bubbles appear in the LA within 3 or maybe up to 5 heart cycles after they opacify. The RA suggests a PFO is present. Sometimes they'll ask the patient to strain, like bearing down a Valsalva maneuver, which can momentarily increase right atrial pressure and help pop open the PFO to allow bubbles across.
Wow, so they can actually see the bubbles crossing if there's a significant opening. What about actual ASDs? Those are real holes, right? Not just flaps.
Correct. Atrial septal defects, ASDs, are actual holes in the wall. Echo can visualize different types of ASDs depending on where they are located in the septum, secundum, primum, sinus venosus. Besides seeing the defect directly, they use color Doppler to see blood flowing across the hole, usually from the higher pressure left atrium to the lower pressure right atrium.
Can it be hard to see them sometimes?
Sometimes. The source notes that occasionally the septum can appear to drop out or look like it's missing in just one particular echo view. But often, this is just an artifact of the ultrasound angle hitting the thin septum just right. Looking from multiple other views or confirming with color Doppler showing no flow across the area usually clarifies whether it's a real hole or just a dropout artifact.
Okay, that makes sense. So we've built up a picture of the basic plumbing and structure. Now let's get into how echo is used when specific problems arise. It really is amazing how versatile this tool is.
It absolutely is. It plays a key role in diagnosing and managing so many different conditions. Let's start with a really common and critical one. Acute coronary syndrome, basically. A heart attack or unstable angina.
How does echo help right away in that urgent situation?
It's vital. One of the first things echo can show, often very quickly, are those regional wall motion abnormalities we talked about earlier.
Parts of the muscle not squeezing right.
Exactly. If a part of the LV muscle isn't squeezing properly or not moving at all, it strongly suggests that the coronary artery supplying that area is blocked or severely narrowed. And the pattern of which walls aren't moving often points directly to which artery is likely the culprit. This helps confirm the diagnosis and guide treatment decisions, like whether the patient needs urgent angiography.
Can it detect complications too?
Yes, and this is critical. Echo can detect serious mechanical complications that can happen, fortunately, rarely, after a major heart attack. Things like a hole tearing through the wall between the ventricles, a ventricular septal rupture, or a rupture of one of the small muscles that anchor the mitral valve. Papillary muscle rupture.
What happens then?
That papillary muscle rupture can cause the mitral valve to suddenly become severely leaky, acute severe mitral regurgitation, which is a surgical emergency. Echo can also assess if parts of the weakened heart wall are starting to balloon outwards, forming an aneurysm.
Okay, shifting gears. What about cardiomyopathies? These are diseases of the heart muscle itself, right?
Correct. Cardiomyopathies are conditions where the heart muscle structure or function is abnormal, but not primarily because of blocked coronary arteries, high blood pressure, or a valve disease, although those things can sometimes coexist. They can be genetic, caused by inflammation, toxins, infections, or sometimes the cause is unknown.
What are the main types that echo helps identify or characterize?
The source describes several key patterns echo looks for. Maybe the most common is dilated cardiomyopathy, DCM.
Dilated meaning?
Meaning the left ventricle becomes enlarged, stretched out, and weakened, like a baggy, worn-out balloon that can't squeeze effectively. Echo confirms this enlargement and reduced ejection fraction, and importantly, helps rule out other potential causes like severe valve disease that might also cause the LV to dilate.
Okay, what else?
Then there's hypertrophic cardiomyopathy, HCM. This is kind of the opposite pattern. Here, the heart muscle wall becomes abnormally thick and hypertrophied.
Thicker muscle, isn't that stronger?
Not necessarily in this case. The thickening is often disorganized and can actually make the ventricle stiff, impairing filling. And importantly, echo assesses the pattern of this thickening. Is it symmetrical, all walls thickened evenly, or more commonly in HCM, is it asymmetrical, with some parts, often the septum, much thicker than others?
Why does the pattern matter?
It helps confirm the diagnosis. Echo also looks for specific features often seen in HCM, like potential obstruction of blood flow out of the left ventricle, just below the aortic valve. This can happen if the thickened septum bulges into the outflow path during contraction. They also look for secondary signs like enlargement of the left atrium and measure features that might indicate a higher risk for sudden cardiac death, such as extreme wall thickness, for example, 30 millimeters or more.
Now, this brings up a really important question, I think. How does the echo specialist tell the difference between HCM, which is a specific genetic disease, and maybe just the heart of a highly trained athlete, which can also be a bit thicker and maybe dilated, or even just thickening caused by years of untreated high blood pressure? That seems like it could be tricky.
It absolutely is tricky, and it's a critical differentiation to make. The source does highlight how echo provides key clues to sort this out. It's not just about the thickness itself.
So what else do they look at?
Well, several things. For example, in a typical athlete's heart adaptation, the LV cavity size usually isn't small. It might even be slightly enlarged, and the left atrium is usually normal size. In contrast, in HCM, the LV cavity might be normal or even small, and the LA is often significantly enlarged due to the filling problems.
Pattern again.
Pattern of thickening is key too. In athletes, any thickening is usually mild and symmetrical. In HCM, as we said, it's frequently marked and asymmetrical. And crucially, those subtle functional measures we discussed earlier, like GLS and tissue Doppler velocity.
A strain and muscle movement speed.
Exactly. The source notes that in an athlete's heart, even if the resting LVEF sometimes looks slightly lower, those subtle measures of intrinsic muscle function, like the S velocity on tissue Doppler and the GLS, are typically normal or even supernormal. They indicate healthy adapted muscle. Whereas in HCM, even if the LVEF looks okay, these subtle measures are often abnormal, reflecting underlying muscle fiber disarray and dysfunction. They might also look at diastolic function parameters.
Ah, okay. So it's really a combination of features, the cavity size, the pattern of thickness, the LA size, and those subtle functional markers that helps distinguish a healthy, trained heart from a diseased, hypertrophied one, or one thickened from hypertension. That's really insightful.
It truly is. It requires integrating all the findings. Okay, other types of cardiomyopathy. There's restrictive cardiomyopathy. Here, the main problem is that the LV muscle is incredibly stiff and rigid, causing severe problems with filling, even though the LV size and wall thickness might look surprisingly normal on echo.
What causes that stiffness?
It can be caused by infiltration of the muscle, for example, by amyloid protein in amyloidosis. Echo shows signs of severely impaired diastolic function and often by atrial enlargement. Then there's non-compaction cardiomyopathy, where parts of the LV muscle, often near the apex, have a distinct, spongy, excessively trabeculated appearance. An arrhythmogenic RV cardiomyopathy, or ARVCD, which primarily affects the right ventricle, causing fatty replacement and scarring, leading to RV dilation, dysfunction, and risk of dangerous arrhythmias. Echo looks for specific criteria related to RV size and function to suggest this diagnosis.
And you mentioned cardio-oncology earlier. Echo is heavily used there, too.
Yes, absolutely essential. Many chemotherapy drugs, while life-saving for cancer, can potentially be toxic to the heart muscle, cardiotoxic. Echo is used routinely to monitor heart function before, during, and after chemotherapy in these patients.
What are they looking for specifically?
Accurate assessment of LVEF is key, but as we mentioned, GLS, that global longitudinal strain, is often even more sensitive for picking up early, subtle signs of cardiotoxicity, sometimes before the LVEF drops significantly. The source emphasizes the importance of consistent, high-quality measurements and gives specific reporting thresholds. For instance, a drop in LVEF by more than 10 percentage points to a value below normal, or a relative drop in GLS by more than 15% from baseline, or GLS worsening to a value greater than negative 16%, closer to zero. These are flags.
Flag does that mean?
They trigger communication between the echo lab and the oncology team. It might lead to adjustments in the cancer treatment, adding heart protective medications or closer monitoring, all aimed at preventing irreversible heart damage while still effectively treating the cancer.
Okay, that makes perfect sense. Let's move to another huge area where echo is just fundamental, valve diseases. This really seems like echo's bread and butter.
It is indeed. Evaluating the heart's 4 valves, the aortic, mitral, tricuspid, and pulmonary valves, is a core function of echocardiography. These valves act like one-way doors, ensuring blood flows in the correct direction through the heart chambers. They can develop 2 main types of problems. They can become narrowed and fail to open properly, which is stenosis, or they can fail to close properly and leak backward, which is regurgitation or insufficiency.
Let's start with the aortic valve again. That's the main door between the left ventricle and the aorta, sending blood out to the body. What happens if it gets narrowed aortic stenosis, AS?
If the aortic valve becomes narrowed, usually due to calcium buildup as people age, or sometimes due to a congenital bicuspid valve, the left ventricle has to work much harder, generating higher pressure to push blood through that restricted opening.
How does echo measure how bad it is?
Echo uses Doppler to measure how fast the blood is forced through that narrowed valve opening the peak velocity, Vmax. It also calculates the pressure difference or gradient across the valve, both the peak gradient and the mean average gradient throughout the ejection period. And perhaps most importantly, it estimates the actual size of the valve opening, the effective orifice area, EOA, usually using something called the continuity equation.
So faster velocity, higher gradient, smaller area mean more severe stenosis.
Exactly. These measurements are used to grade the severity, typically as mild, moderate, or severe AS. The source also discusses some challenging scenarios, like low-flow, low-gradient AS, where the LV might be weak so it can't generate a high velocity or gradient, even if the valve is severely narrowed. This requires careful assessment, sometimes using stress echo or other techniques.
Okay. What if the aortic valve is leaky instead of narrow aortic regurgitation, AR?
If the aortic valve doesn't close tightly, blood leaks backward from the aorta into the left ventricle during diastole, when the LV is supposed to be relaxing and filling from the left atrium. This puts an extra volume load on the LV.
How does echo assess that leak?
Echo looks at the valve structure itself. Why is it leaking? Is it damaged, dilated? Then it uses color Doppler to visualize the regurgitant jet flowing back into the LV. A key measure is the width of the jet at its narrowest point. Just as it emerges from the valve, this is called the vena contracta width. A wider vena contracta suggests a more severe leak. They also look at other signs, like whether the backward flow extends deep into the LV or if there's evidence of flow reversal back down the aorta using pulse Doppler. These help grade the severity.
And you mentioned earlier some red flag signs, specifically in acute severe AR, the kind that might happen suddenly, maybe from endocarditis or dissection.
Yes. The source highlights these because they indicate the heart is acutely overwhelmed and failing to cope with a sudden massive leak. These signs include a hyperdynamic LV, pumping very vigorously trying to compensate, a very short transmitral E wave deceleration time, less than 150 meters, which means the LV pressure is rising extremely rapidly during filling due to the leak, and sometimes even seeing diastolic mitral regurgitation, blood leaking backward through the mitral valve during diastole because the LV pressure gets so high it exceeds the LA pressure. Finding these signs is a critical alert. It suggests hemodynamic instability and likely requires urgent intervention.
Got it. Those are really specific, life-saving signs to recognize. How about the mitral valve, the one between the left atrium and left ventricle? Let's start with narrowing mitral stenosis, MS.
Mitral stenosis, most commonly caused by rheumatic heart disease historically, means the mitral valve is narrowed, obstructing blood flow from the LA to the LV during diastole. This causes pressure to build up in the LA and lungs.
How does echo assess MS severity?
Echo is crucial here. A key technique, especially if the valve anatomy allows, is planimetry. This involves directly tracing the orifice of the mitral valve opening in a specific cross-sectional view during diastole to measure its area, MVA, mitral valve area. They also measure the pressure gradient across the valve using Doppler and calculate the pressure half-time, PHT, which is related to how quickly the pressure difference between the LA and LV falls during diastole. A longer PHT suggests more severe stenosis. Echo also assesses the valve's morphology, how thickened, calcified, and restricted the leaflets are, which helps determine if the patient might be a candidate for a balloon valvotomy procedure to open the valve up.
Okay. And the opposite problem, mitral regurgitation, MR, a leaky mitral valve.
Yes, MR means blood leaks backward from the LV into the LA during systole when the LV contracts. This also puts a volume load on the LV and LA.
How is MR assessed?
Similar principles to AR. Echo first looks at the valve apparatus itself. What's the mechanism of the leak? Is it due to leaflet prolapse, like in mitral valve prolapse syndrome? Is it due to restricted leaflet motion, maybe after rheumatic disease or due to LV issues? Or is the annulus dilated? Then, they use color Doppler to visualize the jet size and extent. Quantitative measures are also very important for grading severity, especially for moderate or severe Michiar-Vor. These include estimating the effective regurgitant orifice area, EROA, the size of the hole through which the blood is leaking, and the regurgitant volume, RVOL, how much blood leaks back with each beat.
And you mentioned distinguishing primary versus secondary misrar?
Yes, this is a key distinction. Primary MR means the problem originates with the valve leaflets or cords themselves, like prolapse, flail leaflet, endocarditis. Secondary or functional MR means the valve itself might be structurally normal, but it leaks because the left ventricle is dilated or abnormally shaped, often due to cardiomyopathy or heart attack, which pulls the papillary muscles apart and prevents the leaflets from closing properly. The treatment approach can differ significantly between primary and secondary MR. The source also notes that seeing a hyperdynamic LV, High LVEF can sometimes be a clue suggesting significant MR might be present, as the LV is ejecting part of its volume easily back into the low-pressure LA.
Makes sense. What about the valves on the right side of the heart, the tricuspid and pulmonary valves? Are they assessed similarly?
Yes, the principles are much the same. Echo assesses their structure and looks for stenosis or regurgitation using Doppler. As we mentioned quite early on, a little bit of tricuspid regurgitation, TR, and pulmonary regurgitation, PR, is extremely common, seen in most healthy individuals, and is considered physiologically normal if it's mild and the valves look normal.
So mild leaks, there are usually nothing.
Usually nothing to worry about. Echo focuses on grading more significant degrees of TR or PR, or identifying if there's tricuspid or pulmonary stenosis, which are much less common than left-sided valve problems. Severe TR, for instance, can significantly affect RV function and lead to symptoms of right heart failure.
Okay. What about people who have had valve surgery and now have prosthetic heart valves, either mechanical ones or tissue valves? How does Echo evaluate those?
Echo is absolutely essential for monitoring prosthetic valves throughout a patient's life. It serves several key functions. First, it identifies the type of valve, mechanical versus bioprosthetic, and assesses its physical appearance. Are the leaflets moving well? Is there any thickening or clot formation? Thrombus.
And funk.
Yes, evaluating function is critical. They use Doppler to measure the velocities and pressure gradients across the prosthetic valve. It's important to know that all prosthetic valves create some degree of obstruction compared to a normal native valve, so slightly elevated velocities and gradients are expected.
So how do you know if it's normal for that prosthesis or if there's a real problem, like stenosis?
That's the challenge. You need to compare the current findings to the patient's baseline study done shortly after surgery, if available. They also calculate indices, the Doppler Velocity Index, DVI, which compares the velocity through the prosthesis to the velocity just before it in the LV outflow tract. A low DVI suggests obstruction. They also look for abnormally high gradients that are significantly increased from baseline. Another issue is patient prosthesis mismatch, PPM, where the implanted valve is technically functioning normally but is simply too small for the patient's body size, leading to high gradients. Echo helps assess for this too.
What about leaks? Can prosthetics leak?
Yes, they check carefully for regurgitation. A tiny bit of washing regurgitation is normal, especially with mechanical valves, designed to prevent stagnation. But Echo looks for significant leaks. These can be transvalvular, through the valve itself, or, more concerningly, paraprosthetic, around the outside edge of the valve where it's sewn in. A new or worsening paraprosthetic leak can indicate infection or that the stitches are coming loose. The source points out a common pitfall, not mistaking the normal, small, often multiple turbulent jets seen with bileaflet mechanical valves for pathological paraprosthetic leaks. Careful technique is needed.
Okay, very important distinctions. Let's talk about infections involving the heart, specifically endocarditis. What's Echo's role there?
Endocarditis is typically an infection, usually bacterial, that settles on the heart valves, but it can also affect the lining of the heart chambers or even implanted devices like pacemakers. Echo is a primary tool for diagnosing endocarditis and assessing its severity and complications.
What does it look for?
The hallmark finding Echo looks for are vegetations. These are essentially mobile or fixed clumps made of bacteria, inflammatory cells, platelets, and fibrin that attach to the infected valve leaflet or other structure. Echo assesses the size and mobility of these vegetations. Larger vegetations, especially 10 millimeter, and highly mobile ones are associated with a higher risk of breaking off, embolizing, and causing a stroke or blocking blood flow elsewhere in the body. The source notes that vegetation size might influence decisions about surgery.
Besides the vegetations themselves, does Echo look for damage caused by the infection?
Critically important, yes. Echo looks for local complications of the infection. This includes things like abscesses forming in the tissue around the valve ring, destruction of the valve leaflet itself leading to perforation or tearing, flail leaflet, which can cause new or worsening severe regurgitation. If the patient has a prosthetic valve, Echo looks for new paraprosthetic leaks, which are highly suspicious for valve infection. Prosthetic valve endocarditis.
And those red flag signs again?
Exactly. Remember those signs of acute severe regurgitation we discussed? Hyperdynamic LV, short filling times. Endocarditis causing sudden valve destruction is a classic cause of that picture, and finding those signs on Echo in a patient suspected of endocarditis is a major red flag, indicating a potential surgical emergency.
Right. Shifting gears slightly, but still related to major structures.
Yeah.
What about assessing the big artery leaving the heart, the aorta, and looking for something really critical, like an aortic dissection.
Yes, the standard transthoracic echo, TTE, routinely measures the diameter of the aorta at several key levels.
Right.
The sinuses of Valsalva, right where it arises from the heart, the ascending aorta, sometimes the arch, and the proximal descending aorta,
Why measure it?
to check for dilatation or aneurysm. The report will provide these measurements, and the source gives typical upper limits of normal. It also mentions specific size thresholds where surgery might be considered to prevent rupture, especially in patients with conditions that weaken the aorta, like Marfan syndrome, or those with a bicuspid aortic valve. These thresholds vary depending on the location and the underlying condition.
And dissection, that's a tear in the wall, right?
Exactly. Aortic dissection is a tear in the inner lining of the aorta, allowing blood to track within the layers of the aortic wall, creating a false lumen alongside the true lumen. It's a life-threatening emergency.
Can Echo see that?
TTE can sometimes visualize the dissection, the torn inner layer flapping in the blood flow, especially in the ascending aorta. It can help differentiate the true lumen from the false lumen. However, TTE is often limited in visualizing the entire aorta, especially the arch and descending portions. The source makes an important point. If the visualized parts of the aorta appear normal in size, a dissection involving those segments is unlikely. But if there's a strong clinical suspicion of dissection, especially involving the arch or descending aorta, a normal TTE does not rule it out. Other imaging, like a CT scan or a transesophageal echo, TOE, is usually necessary for a definitive diagnosis or exclusion.
Okay, good clarification. Echo also plays a significant role in adult congenital heart disease conditions people are born with, even if diagnosed later in life.
Yes, absolutely. Even simple congenital defects that might have been missed or didn't require intervention in childhood are often monitored or first diagnosed in adulthood using echo. This includes things like ASDs, atrial septal defects, and VSDs, ventricular septal defects, holes between the chambers, or a PDA, patent ductus arteriosus, which is a persistent connection between the aorta and pulmonary artery that should normally close after birth.
What does Echo assess in these cases?
It identifies the defect itself and importantly assesses its hemodynamics significance. For shunts, like ASDs, VSDs, PDAs, it estimates the size of the blood flow across the defect, often using a ratio called QPQs, pulmonary flow to systemic flow. It also looks at the impact of the shunt on the heart chambers. For example, a significant ASD typically causes enlargement and volume overload of the right atrium and right ventricle. A significant VSD or PDA tends to cause volume overload of the left atrium and left ventricle. The bubble study we talked about for PFOs is also useful for detecting right to left shunting through these defects.
Does it help with more complex congenital conditions too?
Yes. Echo is used extensively to evaluate patients with more complex congenital heart disease, both before and long-term after surgical repairs. Conditions like tetralogy of Fallot, TOF, Ebstein's anomaly of the tricuspid valve, transposition of the great arteries. Echo provides detailed anatomical and functional assessment to monitor for residual problems or late complications.
Okay. What about problems with the sac that surrounds the heart, the pericardium, pericardial disease?
Right, the pericardium. The most common thing Echo finds related to the pericardium is a pericardial effusion. That's simply fluid collecting in the space between the two layers of the pericardial sac.
Can Echo see that easily?
Very easily. Echo is excellent at detecting pericardial fluid, visualizing it as an echo-free space around the heart. It can estimate the size of the effusion, small, moderate, large, based on where the fluid is seen and how thick the layer is. It's also important to differentiate pericardial fluid around the heart from pleural fluid around the lungs, which can sometimes look similar in certain views.
Does the amount of fluid matter most?
The amount matters, but even more critical is whether that fluid is causing tamponade. Tamponade is a physiological state where the pressure from the effusion fluid becomes high enough to squeeze the heart chambers, particularly the right-sided chambers, which have lower pressure, and prevent them from filling properly during diastole. This can lead to shock and is a medical emergency.
How does Echo tell if there's tamponade? It's not just the size of the effusion.
Correct, it's not just the size. While large effusions are more likely to cause tamponade, the rate at which the fluid accumulates is also crucial. A small effusion that develops very rapidly might cause tamponade, whereas the heart might adapt to a very large effusion that develops slowly over weeks or months. Echo looks for specific signs of tamponade physiology. Classic signs include diastolic collapse of the right atrium and/or right ventricle, meaning they get squished inwards during their filling phase because the pericardial pressure exceeds their internal pressure. A dilated IVC that doesn't collapse with breathing, indicating high right atrial pressure. and exaggerated respiratory variation in blood flow velocities across the mitral and tricuspid valves. Seeing these signs is much more important than just the size of the effusion itself. The source also notes that tamponade can sometimes occur with smaller effusions if the patient has pre-existing severe LV hypertrophy, making the ventricle less compliant.
Okay. What if the problem isn't fluid, but the sac itself becomes stiffened or scarred?
That's called pericardial constriction. This typically happens after inflammation, pericarditis, surgery, or radiation. The pericardium becomes thick, scarred, and non-compliant, acting like a rigid shell around the heart, restricting its diastolic filling globally.
How does echo diagnose constriction? It sounds like it might cause similar filling problems to tamponade or restrictive cardiomyopathy.
It does cause similar filling problems, and differentiating them is key. Echo looks for characteristic signs of constriction. One classic sign is the septal bounce, or shudder. The interventricular septum visibly shifts abruptly towards the LV, early in diastole, as pressures equalize quickly due to the restricted filling. They also look for specific patterns of respiratory variation in Doppler flow velocities across the valves, which are different from those seen in tamponade. And comparing the movement of the heart muscle itself, using tissue Doppler e-velocities, to the blood flow patterns helps distinguish constriction, where muscle relaxation itself might be relatively preserved initially, from restrictive cardiomyopathy, where the muscle itself is stiff and relaxation is impaired. It can be a complex diagnosis, sometimes requiring multiple imaging modalities.
And what about just inflammation of the pericardium, acute pericarditis?
While acute pericarditis is primarily diagnosed based on clinical symptoms, chest pain, often positional, and EKG changes, echo is almost always performed. Why? Mainly to check if there's an associated pericardial effusion, and importantly, to rule out other potential causes of chest pain that might mimic pericarditis, like acute myocarditis, inflammation of the heart muscle, or even an acute coronary syndrome. Usually in uncomplicated pericarditis, the echo might be completely normal, apart from maybe a small effusion.
Okay. Lastly, under structural issues, echo is used to detect masses in or around the heart.
Right. Echo can identify abnormal lumps, bumps, or growths located within the heart chambers, attached to the valves, originating from the heart walls, or sometimes compressing the heart from the outside.
What kind of masses?
It could be a blood clot, known as a thrombus, which often forms in areas of stagnant blood flow, like in an enlarged left atrium in patients with atrial fibrillation, or in the LV apex after a large heart attack. It could be a primary tumor of the heart, which are rare, like myxomas, or, more commonly, metastatic spread from cancer elsewhere in the body. Or, as we discussed with endocarditis, it could be a vegetation.
Can it be hard to tell what a mass is just by looking at it on echo?
It can be very challenging. Echo assesses several features of the mass: its location, which chamber, which valve, which wall, its size, its shape, and echogenicity.
Yeah.
Does it look solid, cyclic, layered? Its mobility, is it fixed or does it move freely? Its site of attachment, is it broadly attached or on a stalk? And whether it seems to be involving or attached to adjacent structures.
Does the patient's situation help?
Absolutely. The source highlights the importance of considering the clinical context. For example, if a patient has known atrial fibrillation and a dilated left atrium, a mobile mass seen in the LA appendage is overwhelmingly likely to be a thrombus. If a patient has known cancer, a new mass seen in the heart might be suspected as metastasis. If they have fever and signs of infection, a mass on a valve is likely a vegetation.
Are there normal structures that can sometimes look like masses?
Yes, definitely. There are several normal anatomical variants, things like prominent trabeculations, the eustachian valve remnant in the right atrium, moderator bands in the RV, accessory chordae that can sometimes be mistaken for pathological masses if the operator isn't careful or experienced. Differentiating these normal variants from true pathology is an important skill. The size and mobility of a true mass are important prognostic factors, as larger, more mobile masses like thrombi or vegetations carry a higher risk of embolization.
It really is just fascinating how much detail and diagnostic information a skilled operator can get from these ultrasound images across such a huge range of potential heart problems.
It truly is. And its utility extends beyond just the stable patient in the outpatient clinic. Echo is an absolutely critical tool in acute and critical care settings as well.
Right, for emergencies.
Exactly. The source lists numerous scenarios where point-of-care echo, often performed right at the bedside by intensivists or emergency physicians, is invaluable. Think about patients with unexplained hypotension, low blood pressure, or shock, acute respiratory failure, acute chest pain, suspected pulmonary embolism.
What can it tell you quickly in those situations?
It can provide rapid answers about the potential cause of the patient's instability. Is the heart contracting vigorously but the chambers look empty? Maybe they're severely underfilled, hypovolemic shock. Is the LV function severely depressed? That suggests cardiogenic shock. Is the RV massively dilated and barely moving? That points towards obstructive shock from a large pulmonary embolism or severe RV failure. Is there a large pericardial effusion with signs of tamponade? That's another cause of obstructive shock. Echo can quickly assess chamber sizes, global and regional function, look for effusion, and estimate volume status and filling pressures using things like the IVC size and collapsibility and basic Doppler parameters. The source even mentions a specific echo checklist designed for rapid evaluation of critically ill patients. It also notes echo's role in monitoring patients with severe COVID-19 who often had cardiac complications.
So it really helps narrow down the cause of critical illness right at the bedside.
Precisely. A very powerful diagnostic tool in urgent situations.
The source also briefly touches on echo findings in a few other scenarios, maybe less common ones.
Yes. It briefly mentions that specific echo findings might be seen in patients with severe chronic obstructive pulmonary disease, COPD, reflecting the effects of lung disease on the right heart. It mentions echoes used in searching for potential cardiac sources of emboli in patients who have had a stroke or clot elsewhere, looking for thrombus, PFO, valve vegetations. And it notes that certain echo findings are sometimes associated with the systemic conditions like HIV infection, certain neuromuscular disorders like muscular dystrophies, systemic inflammatory diseases like lupus or scleroderma, and chronic renal disease.
And you also mentioned it's used to fine-tune certain cardiac devices, like advanced pacemakers.
Exactly. For patients who receive cardiac resynchronization therapy, CRT, that's a special type of pacemaker with leads in both the right and left ventricles designed to help them contract together more efficiently, usually used in heart failure. Patients with bundle branch block echo can be used for CRT optimization.
How does that work?
By making detailed measurements of things like the timing of mitral valve filling or the aortic VTI, that measure of stroke volume, while adjusting the pacemaker's timing settings, like the AV delay or VV timing, the echo specialist can help the electrophysiologist find the settings that result in the most synchronized and efficient heart contraction for that individual patient, maximizing the benefit of the therapy.
And finally, ongoing monitoring in the intensive care unit.
Yes, echo plays a role in critical care monitoring for patients on advanced life support. For example, in patients on ECMO, extracorporeal membrane oxygenation, echo helps confirm the position of the large cannulae, monitors native heart function recovery, and checks for complications. For patients with ventricular assist devices, VADs, or intra-aortic balloon pumps, IABPs, echo helps assess device position and function and monitors the underlying heart's response. So, to kind of bring this all together, this deep dive into the source material really reveals how echocardiography offers this unique, non-invasive, real-time window into the heart structure and mechanics. By looking at its size, how it squeezes and relaxes, how the valves are working, searching for specific abnormalities like clots or effusions. Echo provides just vital clues for diagnosis, for guiding treatment decisions, and for monitoring how patients respond across this incredibly vast range of cardiovascular conditions, from simple checks to complex emergencies.
Yeah. Hopefully this discussion gives you, our listener, a much better handle on the language, the key measurements, and the concepts you might encounter if you see an echocardiogram report or hear doctors discussing one. You now have, well, hopefully a shortcut to feeling more informed and maybe a little less intimidated by all that information.
We've certainly covered a lot of ground, haven't we? Breaking down the different chambers, the valves, the specific measurements. But, the real art and science of interpreting an echo report, as the source clearly implies, lies in integrating all these individual pieces of information. The dimensions, the Doppler numbers, the visual appearance of the valves, the patterns of wall motion, and putting them together within the context of that specific patient. Their symptoms, their history, their overall clinical picture. It's about synthesizing everything.
It really makes you wonder if we can sort of unlock the complexity of an echo report with the right